So we're going to take you through a week in the life of a doctor in training. Now, we've used the term doctor in training rather than junior doctor because there was a big review and we're not to be called junior doctors anymore because apparently that undermines all of our undergraduate training that we've already had. So we are postgraduate doctors in training. And I'll introduce myself a little bit further shortly, and Sarah will introduce herself later on in the talk. So you'll know a bit about us and our backgrounds. So a little bit about me. This is a picture of me heading to my first ever night shift as a fully qualified doctor, back when I still had blue hair, when I still had the enthusiasm to maintain the blue in my hair, which I have now abandoned. So I'm a foundation year 2 doctor working here in the northeast of England. So that means that I qualified from medical school about 18 months ago now, so August 2021. And I'm coming to the end of my first rotation of my FY2 year, and we'll talk a little bit more about what foundation years 1 and 2 mean in a minute. I actually came here to the northeast from King's College London. I'm originally from Kent. I studied in London and I decided to come up to the beautiful northeast because I took a trip to Newcastle when I was a final year medical student and just absolutely fell in love with the place. So last year I was actually working at the Cumberland Infirmary in Carlisle, which again is obviously over sort of a bit more west of the country, which is a little bit different, I think, from some of the experiences Sarah might have had working in the bigger hospitals here in Newcastle. But I had a brilliant time and really, really enjoyed my first year as a junior doctor, which is why we thought it might be nice to tell you all about what it really means being a doctor in your first couple of years out of medical school. So today's session, we're going to take you through a week in the life or a day in the life of a junior doctor who is working in 3 different areas. So we've chosen some sort of very general areas for you. So general medicine, academic research, which it will all become clear while we're talking about that later on, and general surgery. So this is a year 1 newly qualified doctor rotating around 3 different specialties during their first year in postgraduate training. So why is this important for you guys? You're probably thinking, well, it's ages until we're going to be at this point. And I don't know if Sarah will probably share her own experiences later, but it feels like a long time. But for me, it feels like it was basically yesterday that I was opening my emails on the morning of A-level results day to find out that I had indeed got into medical school. And now I've been out of medical school for 18 months. It still feels like a very short time. So I think it's always good to be aware of kind of what's coming next. It's not something to worry about, but just to have a little bit of awareness of what your life might look like kind of after medical school. So as a freshly minted doctor in the UK, unfortunately, we have a system, well, fortunately or unfortunately, depending on your viewpoint, we don't have a system like in the US. So if you've watched Grey's Anatomy or Scrubs or anything like that, you'll notice that the system's a bit different in the US. So they go straight into their sort of specialty training straight from medical school. But in the UK, we have something called the foundation program. So everyone who graduates from medical school in the UK is obliged to work for 2 years in the foundation program. And this is to kind of prepare you for your specialty training. You can then, after the 2 years, apply for, you know, if you want to be a GP or a surgeon, or if like me, you want to be an obstetrician gynecologist, at that point you can go into your specialty training. So F1 and F2 is a 2-year program, and it's set up so that you have, in most places, you have 3 4-month rotations. Sorry, someone's getting a bit excited with their horn outside. So you have 3 4-month rotations in each year. So in your FY1 year, you'll be very, very heavily supervised. In your FY2 year, you start getting a little bit more independent. You may be given a bit more responsibility for assessing and reviewing patients and things like that. Usually some of the specific specialties are also reserved for FY2s rather than FY1s. So for instance, I'm currently working in general practice. FY1s don't work in general practice. So as an FY1, you'd be based purely in hospital specialties. And I don't anticipate that's going to change massively in the next few years. So this will probably still apply to you guys when you come out of medical school. So first of all, we're going to chat about a kind of day in the life of someone working on general medicine. So my first job was on general medicine, my very first FY1 job. So I thought it would be a good thing to talk about. So, general medicine involves looking after patients with a wide range of medical problems. And I think this was something that really confused me when I first went to medical school, was people talking about, oh, I'm the medical FY1. And I was like, well, isn't it all medical? They're in a hospital. But no, there does tend to be quite a big divide in hospitals between the medical specialties and the surgical specialties, which Sarah's going to talk about a bit later. And these patients do tend to be cared to in separate areas. The allied health professionals that work on medical wards versus surgical wards will also have different types of knowledge. So a nurse who mostly works on the acute medical unit might not work on, say, the orthopedic unit. So there really does tend to be quite a big divide. And as you'll see later on in the talk, there is also quite big differences between the way that the days are set up in medicine and surgery as well. So some patients will be cared for on general medical wards, where there's a mixture of patients with different diseases, problems. Some will be cared for on specialist wards, depending on exactly what's wrong with them. And most patients who come into the hospital through A&E will also start off in a sort of admissions unit, so sometimes called an acute medical unit, sometimes called the medical assessments unit, and that is sort of where the initial tests are done to decide what's wrong with someone, whether they can go home or whether they need to go to a special medical ward to have more treatment. So I've just listed a few of the different specialties that sort of fall under medicine. These are the main ones that you'll find in like every single hospital. Some hospitals will have like super specialized wards. So I know that some of the big hospitals here in Newcastle will have very, very specialized medical wards, but these are like basically the ones that we had in my little DGH in Carlisle that I worked in. So cardiology is to do with the heart. So you'd see people who have heart attacks, things like that. Respiratory, obviously there was a lot of COVID in respiratory because that's lung disease, but you also see some people with maybe severe asthma and things like that. Renal, it's to do with the kidneys. There's often a special cancer ward, which is for anyone who's having treatments like chemotherapy. Most hospitals will also have a specific elderly care ward that might have people like specialized physiotherapists who are trained to kind of help people get back into their homes when they're elderly and maybe they've had a fall. And obviously gastroenterology is to do with like the stomach and the bowels. So the setup of a day in general medicine normally starts at 9, and you'll see why that's important when you come to looking at the surgical specialties later. So generally in medicine, the day will start with a ward round, and the whole team, including the nurses, sometimes people like physios, sometimes people like dietitians who help support people with their nutrition, will visit each patient on the ward to review their progress. And usually as the most junior doctor on the ward, you might be assigned to writing down all of the information from the ward round, so scribing. You'll also be making a list of the jobs that you need to do for each patient throughout the day, but we'll come on to that again in a little bit. So medical ward rounds do tend to take a little bit of time because the patients can be quite complex. Lots and lots of people who are in hospital in the UK in 2022 have got more than one problem and will be cared for by more than one team, and that can often be quite difficult to sort of bring all of those things together, and you have to kind of constantly be asking yourself sort of what is keeping this person in hospital, what are the barriers to them going home, because obviously we don't want people to be staying in hospital for weeks and weeks and weeks, particularly if we're not doing anything for them that couldn't be done when they're in their own home, which is a much better and much safer place for people to be. So 11 a.m. you've had a nice a 2-hour ward round in medicine is actually pretty good going, to be honest with you. Sometimes it can take a really long time to get around all of the patients. So most places at 11 a.m, all the junior doctors on the ward will sit down and make sure that they've written down all of the jobs for each patient that they've seen, and share them out evenly. So junior doctors like F1s and F2s really are the people who are responsible for making things happen on the ward. So we'll be the people calling the scanners and asking for scans. We'll be the people taking bloods. We'll be the people making sure that people are ready to go home if they are ready to be discharged. So writing discharge summaries so that the GP knows what's happened to the person in hospital, and making sure people have got any medications and things that they need to get home. So I put 2 p.m. lunch. Again, that can vary quite a lot depending on how busy you are. It's sometimes a bit later than that, but a lot of teams do try to have lunch together, or at least make sure that there's 2 or 3 people going for lunch together, so that you're, not sat in the canteen eating your sandwich by yourself. So the jobs list, this is kind of like what rules your life, I think, day to day as a junior doctor. And there's a very specific box system that it's one of those things that you don't even know how you've learnt to do it like this. It's just you've seen everyone else doing it. And it sort of involves using boxes and sort of half colouring them in and then fully colouring them in. And it's a very complicated system, which I didn't think would be very interesting to go into. But I've got this nice picture of ticks in boxes, which doesn't actually tend to be what people use, weirdly. So the jobs list will be used to keep track of everything that needs to get done on the ward. Some wards will have shared jobs lists, so on a whiteboard or things like that. In other places, you might divide up the patients between yourselves and have your own personal jobs list. But the real key thing is to kind of make sure you're always checking in with your colleagues, making sure that no one's overwhelmed, that all of the jobs are sort of shared out fairly. And if you finish your jobs early, you can always help someone else with theirs, because there's always something that needs to be done. So a big part of working in medicine as well is on calls. So this would be your kind of out of hours shifts. So any evening shifts, weekends, night shifts, or if there's something like a bank holiday or you're working over Christmas, which you may well be as a very junior doctor, you would be on call. So it's come out quite blurry, actually. It looks much blurrier now that I've made the full screen. Has anyone ever seen one of these before? Because I don't think I really had seen one of these before. Someone handed me one on my first day and said, "Here's your bleep." So this is a pager. It's a archaic form of communication, but essentially it makes a really, really loud, annoying noise. And then you get a number like this and you go to the nearest phone and you call it, and you have no idea what's happening on the other end of that phone. It could be someone wanting you immediately, or it could be somebody wanting you to come and prescribe some paracetamol in 5 hours. So I find holding the bleep quite stressful, to be honest. I know in other trusts, and Sarah, it's probably true of your experience, they actually have like little phones, which I think are a bit better, but lots of hospitals do still use these bleeps. And given how long they've used them already, I would imagine that they will keep using them. Sometimes when you're on call, you really can feel like your life is ruled by the bleep, because you're sort of in the middle of doing something, and you get another bleep and you're trying to go on the phone with one hand and like write something down with the other hand. But ultimately your list is still your sort of guiding light, because you can always make sure, as long as you're communicating well with the person on the other end of the phone, about when you might be there, other things that you need to do, what's more urgent. People are very happy to wait for you to come and do things if you're seeing an acutely unwell patient. But I think it's one of those sort of universal experience for people who's been junior doctors, is the sound of the bleep. And you do sort of start hearing it sometimes when you're not at work, or you pick up a phone when you're not at work and you say, "Oh, hi, it's Anna Harvey, I'm the FY1 from XYZ ward." So sometimes it does sort of seep into your psyche, but hopefully there won't be too many bleeps around by the time you guys are maybe doing on calls, but there certainly will be a way to contact you that will be used liberally by other people in the hospital. I just think it's a bit quite funny that they're still using these, but it works. They never really go down, so I guess that's the main thing. Fine. So this is just something for you guys to, I'm just going to give you a few minutes whilst I'm talking through my reasoning of kind of prioritizing these patients, but just having a think about how you might prioritize things, because as I was saying, when we do these on calls, sometimes you do get sort of multiple things coming in at the same time, and you have to sort of make a decision in your head about which patient is most important that you're going to go to first. So I thought it might be nice for you guys to just have a little think about what you might do if you were on call, and say you had 3 phone calls back to back, and it was these 3 patients. So the first one is a nurse who rings you and says, "Oh, doctor, you must come because this patient's having some trouble breathing." And you say, "Okay, fine." And your bleep goes off again, and it's another nurse on the other end of the hospital, so you can't even see them both at the same time, saying, "Oh, can you please come and see this person who's fainted in the toilet?" Okay, fine. And then patient number 3, your third phone call, is someone who has come into hospital and been diagnosed with a new cancer and wants you to talk to their relatives about it because their relatives are really upset that this has happened. So that's just a little activity for you to think about for a minute, and I'll kind of tell you my reasoning as to sort of which patient that I would go to. But before I do that, just to emphasize that, if you are ever in a situation like this, you're always welcome to ask for more information. So I would definitely, my first step would be wanting to get a bit more information about some of these patients. So I think particularly patients 1 and 2, you would want to get some more information. So the person who's fainted, are they conscious now, or are they just on the floor not doing anything? Have they got up and got themselves back into bed, in which case that's maybe going sort of lower down your priorities than the person who's having trouble breathing. With the person who's having trouble breathing, what kind of things we might think about is, can we look at how much oxygen is currently going into their blood using a SATS probe that goes onto your finger? Is there any sign that they've got any sort of swelling in the face or the tongue that might suggest that they're having a serious allergic reaction? Have they come in with breathing problems and this has just got worse, or is this a completely new breathing problem and they're in for something completely different? So a lot of your job as a junior doctor is about sort of information gathering and prioritizing, and I think I've actually laid these patients out in the order that I would go to them. So I think someone who's fainted, and if you get the information that, okay, they've fainted, but they've got back up, we've helped them into bed, they don't seem like they're injured, they didn't hit their head, then that would definitely be lower down on your priorities than someone who's having trouble breathing. So we kind of use this ABC approach often to looking at people who are acutely unwell. So that stands for airway, breathing, circulation, which if any of you have done any sort of first aid courses, you probably come across this because it's a very, very sort of widely used concept. But we always worry about someone who's got an airway problem before we worry about someone who's got a breathing problem, before we worry about someone who's got a circulation problem, which I think sometimes when I first learned about this, I found it slightly counterintuitive, because I would be like, well, if someone's hemorrhaging out blood, then I'm obviously going to go and deal with them. But actually they will live longer than someone who has choked and can't get any air into their airway. So it does kind of make sense, but that's sort of the basics of what we use to do some of these sort of prioritization exercises when we're on call. And I'm sure that Sarah will share some of her experiences of being on call as well. And sometimes you do just get sort of quite funny calls. I know a lot of people have had calls for like, there's a pigeon in the hospital, please can you come and deal with it? And they're sort of like, well, I don't know how I would deal with that. But yeah, it's a really interesting experience, because you get to see lots and lots of different things and acutely unwell patients, and kind of be the first person there dealing with them and escalating them. So it's a really good learning experience as well if you're a very junior doctor. So I'm going to hand over to Sarah now, who's going to talk about academic research and surgery. So take it away, Sarah.
Hello, are you all right? So my name's as we said, my name's Sarah. So I'm also an FY2 doctor, and I work in the northeast of England as well. So my hospitals, instead of being based across in Carlisle, are between the RVI and the Freeman in the centre of Newcastle. So it is, I suppose we touched on that, a slightly different experience. They're very large centres, they're very busy centres, but at the same time it's very subspecialised. So you at the front door do see a lot of the general take. So you have our medical assessment suite, where you will see all those patients coming through, and thereafterwards they're admitted to very subspecialised wards. So if somebody says admitted to oncology ward, we're really lucky we have a whole oncology hospital. Within respiratory, elderly care, and there's often numerous wards which have sometimes a slightly different take, sometimes just bigger capacity. And we'll kind of touch on it in terms of surgery, but certain procedures are done in Newcastle, which would only be done across certain centres in the whole country. So it's an exciting place to work. It's a different experience as a junior, but I've really enjoyed my same amount of time as Anna, my 18 months or so far here. And I'm looking forward to doing the rest of my second year as a doctor, and possibly staying a bit longer term. I came from the kind of opposite end of the country, if you like. I'm from Glasgow, and I did my undergraduate studies at Glasgow University, and then decided to come down to Newcastle to start working. It was nice sometimes to go somewhere different from where you studied to work, and as we've touched on, Newcastle has an excellent reputation. It's really good for training. It's really good in terms of that support which they can provide, and it's a very nice place to be a junior doctor as well. So I've really enjoyed that, and that's a picture of me on my graduation day. There will be in scrubs later on, but yeah, and I suppose we've touched on it as well, but saying about all these things now, the time really does fly by. I thoroughly remember opening what was instead my advanced hires results, and knowing that I'd gone to university. So I suppose showing interest and awareness. I'm so impressed by how many people are here today. Does show that you're interested, does show that you're thinking about these things. And this part of the pathway is the part of the pathway you'll be on first, if you are interested in pursuing a career in medicine. And I'm so sorry, I'm aware you're in control of the screen, so you click on to the next one. Cool. So the first part I'm going to be talking about is that this is your second rotation of FY1, and for a couple of hundred doctors or so each year in the UK, that is academic research. Anna and I are both on what's now called the Specialised Foundation Programme, was until last year called the Academic Foundation Programme, but effectively means the same thing in that part of our programme is set up and is designed for us to do more in the way of research than would be in a normal foundation programme, and allow us to kind of dip our toe in that a wee bit earlier. And there's lots of doctors who do choose to do that. So we're going to be talking a wee bit about what that might look like if that was something you're interested in getting involved in. And there's often lots of opportunities throughout your medical degree to get a bit more involved in research, to do it as part of special modules you might do. You might do an intercalated degree, which could either be a master's or BSc, and get a bit more involved in research. But most doctors in some capacity are involved in research, and we're all involved with bringing forward the findings of research into our patient care. It's how we learn what the best antihypertensive drug to give someone is. It's how we know the best way to manage a heart attack. We give them these medicines, not these medicines, because we have done a trial which shows that one is better than the other. So even if you're not directly involved in research, it will touch your practice and it will touch your engagement with patients. So we go on to the next slide. Kind of given the spoiler away in this is that we're part of the Specialist Foundation Programme, and I've kind of talked about the things you think about in terms of research. A lot of you will have seen the news around COVID, around development of COVID vaccines, around the trials which led up to that, and there's so many different aspects of research. Education research comes into it. How do we best teach people? And so a lot of doctors here in the Specialist Foundation Programme have a role in teaching, as both Anna and myself do. And in terms of saying leadership, it's part of the role of being a doctor, being able to be a really, really good team player, and also in the correct environments, being able to take on leadership roles within those teams, being able to take direction leadership from others, So it's a team sport medicine. And you can look at leadership more formally through a specialist foundation programme in terms of the structures in medicine, and kind of learning more theory surrounding that. So the specialist foundation programme lets you become a little bit more subspecialised at a more junior level and find out if that's correct for you, or if you would like to use your career to explore something else. So we go on to the next slide. We're thinking about here just in terms of types of research. And I suppose I've touched on that, and we maybe, when we think of research, we might all think of the picture on the right. You're looking at slides, whatever's on there, is it bacteria, is it types of tissues, and that's probably more what you do in high school, is you're looking at the kind of very scientific side of things. And a lot of doctors that are involved in research are involved in what we would call basic science research, which is right down at the cellular level, right down to the molecular level in terms of genetics, thinking about that. And that's how you then go into perhaps a different type of research in terms of how do we test new medicines, how do we test drugs, how do we find out which drugs work. We then might do that in terms of clinical trials, which is yet another type of research, and I'm involved a wee bit in those myself in terms of development of new cancer drugs. And then you can begin to look at all the publications from these. You can bring that research together, and that's in things like systematic reviews in terms of narrative summaries of the papers that you're looking at don't have a lot of data on them. And so a type of research is critiquing other people's research. You might be involved in epidemiological research, which is looking out across populations, across how the prevalence of diseases, why do diseases occur, in terms of formally understanding that. Really famous early studies in those were the doctor studies, which looked at the fact that smoking actually caused lung cancer. Until we had research in that, they couldn't formally say that. And that was part of a follow-up study. So there's lots of different types of research and ways in which we can answer questions that we have about diseases, that we have about people, and ultimately we have about managing our patients. And this is something that you can get involved in at a junior stage. Like I said, a lot of people are actually involved in it in some capacity in medical school. And we'll engage with research groups or learn a bit about what they're doing. You might do a bit of kind of audit or data collection for them, and you can get more formally involved in it in terms of doing intercalated degrees. I think in terms of talking about it, I certainly, it's something that I find really exciting, I find really interesting, I find really engaging as part of the role of a doctor. And staying up to date with research, with our latest treatments, our latest recommendations, our latest knowledge about diseases is how we effectively are constantly learning being a doctor. So in terms of part of the job, it's constant learning, it's constantly changing. Things that I'm learning now as a junior are very different than what my consultants learned when they were junior doctors in terms of the management of things. I've said I work in oncology. The drugs that we have available to treat cancers now are massively different from, say, when my consultant was my age. And that's actually, they're obviously more senior, but they're not very old. So across the space of, say, 10 or 20 years, things can move on massively. And it's through medical research that we make those advances. So that's something that you can do as a junior doctor and you can be involved in. Going on to the next slide. In terms of what might a day in this look like if you're on your research block, what are you doing? And kind of arbitrarily said, the day might start about 8:30. You often have a wee bit more in terms of autonomy of your time, but you might need to plan your time more directly. So say emails, coffee, you communicate via emails all the time, check your diary, know what upcoming meetings you have, make a plan for the day. Are you in the lab that day? Do you need to get in early to make sure everything's set up? Are you following up with research studies that day? Do you have to have a presentation ready? Various different ways your day can start. So there's a lot of variability in what a day might look like in research. Around 10 o'clock, maybe you have a research meeting with your supervisor. Maybe you're talking about the draft of a paper or something you've written. Abstracts are kind of like little mini papers that we would write to submit to meetings, to conferences, and maybe present as an oral presentation or as a poster, something that we've been working on. And I suppose that's a big aspect in terms of communication, in terms of sharing our findings with the rest of the scientific community. And that sparks connections, that's networking. You get involved with other groups who are looking at similar things. And that all comes down to you planning that with your supervisors. And then say around 2 o'clock, you might have finished up some of your work for the day. And then in terms of being a kind of a junior expert in this area, in terms of wanting to learn more, a lot of your work day might revolve around reading, might revolve around absorbing other people's research, learning more about the area that you're looking at. If you're thinking of beginning to explore your patient cohort for a certain aspect, what's already published out, what's already out there, what do we know, and in terms of formulating questions, what do we want to find out? So a day in research might arguably shorter, can sometimes be quite substantially longer. There might be travelling involved if you're needing to go to a meeting in a different part of the country. So it can be quite highly variable. And I certainly do find that as well. In my role, I see quite a lot of patients. I see them in the clinical trials unit and review them. So it can be quite patient-facing or quite non-patient facing. And you can design that yourself in terms of what you're most interested in. So I think just at this stage, knowing that there's an ability to be involved with that at an early point in your career is really exciting, and is something that some of you might want to go on to do, or might think, that's not for me. I'm most interested in working in a more acute environment, reviewing sick patients all the time. And there's research involved in that as well. But it is quite an interesting, quite a varied day and week that you might have within a research unit. So I suppose you can go into the next slide if that's all right. And I'm also going to talk about what might general surgery look like. The term general surgery is often used kind of more interchangeably with it's kind of intra-abdominal surgery. We think of things like appendicitis, we think of things like cholecystitis, and there's a whole training pathway to be a general surgeon instead of a subspecialised surgeon. But that's something that at your stage I was certainly much less clear on what does that mean. So we can unpack that a little bit, and what does that mean for the junior doctor that's working within that role. We go on to the next slide. Thank you very much for changing the manner. And what I'm talking about surgery. What is surgery? So effectively what we're referring to here is diseases and conditions that cannot be managed safely or sufficiently by medications alone. And an operation would be the best treatment for the patient. So an interventional procedure would be the optimal management of that condition. I've kind of touched upon the fact, and some of you might have had operations in the past, things like appendicitis, getting your appendix out when that's inflamed, can be managed with antibiotics, but the optimal treatment is arguably by removal of the appendix. An abscess, collection of pus under the skin, can get them in various places for various reasons. You can give antibiotics for it, give painkillers, but often what's necessary is to drain the abscess, make a small incision, and get that pus, get that infection out of there, give it a way to work its way out of the body. So these are ways in which we manage that. And this is a bit what an operating theatre might look like. Some of you might have been in work experience before, had taster days in the hospital, but it can look like quite an alien and scary environment. And two of these are stock images, and one of them is a real image. I am one of these people. I wouldn't expect you to spot me, but I'm in the middle bluer image in the background, kind of staring directly at the camera. That was during what we call a Whipple's procedure, which is a really funny name. But it's someone's surname that they've lifted, and it's in terms of when they're removing part of the pancreas for various reasons. And that was filmed as part of a TV show, which some of you might have watched, which was about Newcastle Hospital. So it was called Geordie Hospital. It's probably still available online. It's a good insight into what goes on in the hospital, what's the day-to-day interactions of the staff. So that was really enjoyable. So as quite a junior role in that department, you are actively encouraged to go to theatre, to engage with that, to learn from the surgeons, and to within simple things like suturing up part of the skin, like draining a small abscess, under appropriate supervision can get involved in that. Obviously, it's at a very early stage of your training. If you want to go on to subspecialise within surgery, then you'd undergo further training for that. And all of the same things that Anna chatted about in terms of being on call, in terms of making sure the ward runs well, in terms of putting cannulas into the patients, which are little points of access into their blood so that we can give medicine into a vein. In terms of taking blood, so we can see what people's infection markers and things are doing. That would still be your responsibility as well. So often those are shared amongst the team. We try to spend some time in the ward environment and some time in the surgery, the theatre environment. Going on to the next slide, I'd set up a wee bit of an activity, and I'm aware interaction is a wee bit limited. So effectively, what I didn't have a good understanding of prior to starting medical school, and what I think you don't think so much about, is just how widely varied surgery is. So we're talking in terms of your rotation might be on general surgery, but especially in places like Newcastle, where there's lots and lots of different surgical departments, you might be in a different department with a different set of subspecialist surgeons, and they all do different operations. Those different operations mean different things. There's slightly different management for their patients. So not that I've included it in this, but what my idea of this activity was just spend a wee minute or so looking at it while I'm talking. And can you match the surgeon in the left-hand column up to what operation they might be doing, and what does that operation mean? Some of them are a wee bit easier than others, but it does give a wee insight into the kind of dizzying array of things that you might be involved in. And certainly in the RVI in my first year of being a doctor, I was on general surgical rotation, but that was assigned to the upper gastrointestinal surgical team. And they do really, really cool procedures. They've got a surgical robot, which they can use to remove parts of the esophagus. So it's really fascinating stuff, which you can get involved with, and you're as responsible, but you're share the responsibility with the rest of the team of looking after these patients that have really complex procedures done. Okay, so hopefully you've all had a wee chance to look at that. And if you go on to the next slide, we can go through just some of the answers. A lot of you might have got an orthopedic surgeon who looks after your bones. You do lots of different things. It could be removing tumours from bones or fixing your bones when you break them. That could be done by a thing called internal fixation, using plates, using screws. If you break your hip, they might replace your hip. If you have arthritis in your knee, they can replace that as well. Lots of really cool, really interesting procedures. Plastic surgeons, in this example, I've said that they might be involved in doing a reduction mammoplasty, which could be is used for reducing breast size. We often think in terms of them doing cosmetic procedures, but they're also involved in and responsible for the management of patients who come in with burns in terms of skin grafts. So they're involved in really, really cool things. Neurosurgeons, the Grey's Anatomy fans will be familiar with, I'm sure. But if somebody has for some reason bled into and around their brain, they might manage that as an emergency with a burr hole, which allows them to evacuate the blood from that and relieve the pressure on your brain. And then another example, which I wasn't familiar with prior to my training, is a maxillofacial surgeon. They have a really unusual training pathway in that they currently are both doctors and dentists. The more normal training pathway for that, path better travelled, is that they've done a dental degree, and then they do either a full or a slightly abridged medical degree, and they operate around the face and mouth, and they might be responsible for removing a mouth cancer, so say a cancer that's formed in your tongue or the inside of your cheek, and that could be done by a resection of that area. And then in terms of repairing the area, they might do something called a free flap, which is when they take another part of your body, another area of that, along with its blood supply, replumbing the blood supply so that tissue can be vascularized and can live in another part of your body. And so an example that they do, and I've assisted in surgery for, is they can lift up part of the area there, which is supplied by the radial artery, and use it to make a new part of your tongue, which will be vascularized by its own artery from there. So the things that surgeons can do are mind-boggling, really, really cool. And it's an interesting area to work as a junior doctor, because you get a little bit of an exposure and a little bit of insight into these, and an understanding of how we manage these conditions, using both medical and surgical knowledge. We just go on to the next one there. So I've chatted a lot about kind of broadly speaking, what is surgery, because we get this picture in TV, picture in 24 hours in A&E. And then so what is that actually? And then what does the surgical day look like for a junior doctor? Nana did allude to this. It starts a bit earlier. General surgery tends to start at 8 a.m. So you might be in a bit earlier for that. So you need to print off lists or just organise one or two things before. You might be in work a wee bit before 8 o'clock. In terms of, we chat a wee bit about ward rounds, where you go around and see all the patients. And then, so the patients on this ward round instead will be the surgical patients. They'll be the ones that the surgeons are looking after. The optimal management of their condition might require an operation. Not all of them will get one for various reasons, but that's who they're under, they're being looked after in the hospital. The ward rounds in general surgery are famously a little bit quicker. I suppose there's perhaps more of a focus on the kind of primary reason why the patient's in hospital, as opposed to looking right across every single thing that patient might have, but they tend to run a little bit quicker, and say by about 9 a.m, certainly before 10, before the theatre lists start and the people who are operating to go off to do that, you'll get an idea, assign the jobs for the day, and if there's enough of you on the ward, which sometimes there is, sometimes there isn't, then some of the juniors might then say, okay, I did the ward jobs yesterday, today I'm going to go along to one of the surgeon's lists and I'm going to help her with her operation, and then I'm going to go to see some endoscopy. And so you can dip in and out. You might again do the same in medicine if you're going to go to a clinic, but in surgery the day kind of starts a wee bit earlier with that. It does tend to run all the way through to 5 o'clock. Surgical wards can be really, really busy. And then certainly in the RVI, there's often kind of board round. So don't go around all the patients again. You look at them in the board or on the computer, and you talk through what's happened to them that day. Turnover can be quite fast. A lot of people come in, get operated on, go home the same day. Or any patients that are admitted on the on-call take of those surgeons. They're the acute patients who say come in, oh, side sore, got appendicitis, come in, get operated on. You'll discuss those patients as well. On-calls in general surgery, in terms of being the junior doctor on call and being called to come and see people who are a bit less well, can work in a similar way to medicine. And then in terms of people being admitted, there's often an admitting surgeon it's their on-call period of time. So it's really dynamic, it's really fast-paced, and it's certainly a great learning experience as junior doctor in terms of looking after quite unwell patients, and obviously knowing when to escalate, when to get help, and thinking through your basic principles, your airway, your breathing, your circulation, and getting help with that when you need it. So it's really interesting, and it's certainly part of a learning experience that you go through. If you go on to go to medical school and get part of these great jobs you can do as a junior doctor, it's certainly something I've thoroughly enjoyed.
I think sometimes when people work in different hospitals, they can have really very different experiences. So it's always nice, like as a junior, to hear about what other people have been doing and the experiences they've had. I certainly had lots of opportunities to go to theatre when I was on my general surgery job, which was really, really nice. And yeah, I found it really, really interesting, and lots of opportunities to develop practical skills, which can be really cool. Even if you decide that you don't want to be a surgeon, it can still be cool to learn some of those things. So yeah, this is just a little summary of the session. We wanted to leave plenty of time for questions, and I can see that there are quite a few coming through, so we might not have time for all of them. But yeah, a week in the life of a year one newly qualified doctor can be incredibly varied depending on where you're working, what department you're working in, exactly what shifts you're working that week. But we work in a variety of roles, and we work with a lot of different allied health professionals and different teams, from consultants and very, very highly specialist nurses, all the way through to people like us who are on their first year postgraduate, and all sorts of other professions. So it's a really, really interesting job to do. And one of my kind of key reflections from my time at medical school and now being a junior doctor is, I think a lot of people said to me when I was 18, is this not a big decision for you to make at the age of 18 that you're going to do this for the rest of your life? But actually I can't think of something else that I could have picked that would have led to having the opportunities to do such a variety of things, because you know, coming towards the middle of my sort of F2 year now and thinking about where I'm going next, you know, I could apply to be a psychiatrist, or I could apply to be a neurosurgeon, and that's both to do with the brain, but very different spectrum of what you would be doing day to day, and kind of the sort of skills that you might need. So it's a really, really varied career, and there's loads and loads of opportunities within it. So I certainly would still recommend medicine as a career.
I've got a few picked out. If you're happy for me just to pick a few out to ask you both, if that's okay.
Yeah, definitely.
Yeah,
That's
okay.
great.
One thing that we got asked more towards the start of the talk, a few people asked, is what's the work-life balance like, and how do you sort of manage that as a junior doctor?
Yeah, I mean, I'm happy to start, and then I'll hand over to Sarah to hear her experiences. Again, I think it is a very individual thing, and I think what you need to remember is that you will have the whole of medical school to develop some of those skills. But I think for me personally, it has been being quite, I think, specific about how I use my time. And I think particularly, you know, if you are staying late and things like that, there are mechanisms within the hospital where you can report those things, and either get paid for them, or actually sort of recoup that time off. So I think in terms of, you know, working outside of your hours, there are things that we can do as junior doctors that sort of protect us from that. In terms of kind of protecting work-life balance just with the shift work, sometimes it can be a little bit wild. I know when I was working on the acute medical unit, you know, I would do stretches where I would do sort of 7 days on call, which would be like 12.5 hour days, and that is it's tough to do that. But I think the thing to remember is that there's always colleagues to talk to, and there's always support if you need it. Lots of people work less than full time as well. I know plenty of F1s who work at sort of 80%, so they're working a bit less than you might do if you were working full time, which extends the amount of time you spend as an F1. But it's a really, really good option, particularly for people who maybe have additional needs or have caring responsibilities, and things like that. So, and I think it is getting better, and I think hopefully by the time the people in the audience are you know, getting to be junior doctors, it will be even better than it is now. But Sarah, I don't know what your experiences are.
Yeah, so I think I think I echo all of that really. I would say, and I noticed one or two things come up in the chat about it. Say someone was like asked about Duke of Edinburgh Award. What do you enjoy about that? Do you like being outdoors? Do you like going camping? Do you like hill walking? Maintaining, throughout school I learned guitar. I love playing guitar. It's a great way to unwind. Having interests outside of medicine is really important. And right now a lot of you might be focused on it in terms of things like, oh, these are my school hobbies. This shows that I'm a good candidate for medicine. This shows that I'm engaged in other things apart from my schoolwork. They're great things for life. Having interests outside of your job is really important, really nice, and can help actively maintain that balance. And I would say as well that medicine, and certainly different people have different experiences of this. I work in quite a large city, and medicine itself can be quite a sociable and work environment. I'm going to my department's Christmas night out in a couple of weeks' time. There's quite often something organised, certainly on a kind of fortnightly basis, for the junior doctors to say go to a quiz, or something along those lines. So it's something that I think can propagate that, and I think just maintaining your own interests outside of it is crucial to helping to maintain that. So I think it is manageable.
Thank you. Another question we've had is, do you think that medical school prepared you for F1 and F2? And if not, what were the biggest challenges you faced?
Yeah, that's a really interesting one. When Sarah was talking about research and things, I don't know if you mentioned, because I was trying to answer some questions in the chat as well, but my area of research is actually educational research. So one of the things that I'm interested in is whether people feel prepared to be doctors. It's a huge area actually within medical education research, is how we can make people feel more prepared. And actually what we know from the research is that most people don't feel completely prepared. And I think that partially that is gaps in medical school. And I think some of that can be addressed by doing more sort of workplace-based learning. And I know that a lot of medical schools, and particularly at Newcastle, very, very different from my medical school, King's, is a very sort of integrated curriculum. So they have first year medical students on the wards. You know, I was looking after some of them when I was in Carlisle. I never set foot near a hospital until I was a third year. So I think that medical schools do have a recognition that they need to prepare people better. But equally, I do think that there are some things that you might not feel completely prepared for it, but in order to actually learn, you do have to sort of be at the edge of your comfort zone sometimes. I don't know if anyone does weightlifting here, but sometimes you have to come close to failure, right, in order to you know, like build muscle and be able to lift more. And I think there's a similar concept in medicine. Sometimes you do have to be a little bit outside of your comfort zone because that's where you learn. But I think the important thing to remember as a very junior doctor is that there's always someone there. You know, you can always pick up the phone and call someone more senior, even if it's just to say, this is what I've done, this is how I've addressed the problems, is there anything else I need to do, is there anything you think I've missed? It's I've never had anyone be annoyed with me. I think that there can be this kind of reputation that, oh, you should be able to cope with XYZ on your own, but actually people would much rather that you recognized where, you know, your knowledge gaps were. And I think that is a huge part of the skill of being not just a junior doctor, even consultants. Like, I've seen consultants ring up colleagues across the country and be like, I don't know what to do, what do you think about this? So there is always this kind of community, and I think that's one of the nice things about medicine, is that you become sort of part of a community that's geographically very large, because medicine is so similar no matter where you are in the world, but I think also quite sort of temporary large as well. So you're part of a long history of doctors, which always sort of appealed to me. And one story that I sometimes tell to people who are talking about like feeling whether they would feel isolated in medicine and stuff, is I was once at a birthday party for a friend of mine who was another medical student. I was with my partner who's not medical, and I was sat chatting to this other medical student. She was a couple of years above me at King's. Sat chatting to her for a good couple of hours, and when she left at the end of the night, Connor said to me, he was like, oh, I didn't realize you knew each other. And I was like, oh, we just met today. We were just talking about, you know, medical school and medicine. And I think it often is like that. You have that sort of point of connection with people, even if you maybe don't have that much in common outside of medicine. You can always like kind of talk a bit about medicine, which I think is always really nice. Probably if you're not medical and you're sat with like lots of other medical people, you're like, can't get a word in edgeways. But yeah, sorry, I talked for a long time there, Sarah.
No, I think much the same for that in terms of preparation. A lot of I would say things that are hard when you start working is almost being able to put things into practice. You have all the knowledge. Medical schools, obviously, for various different curriculums. Glasgow is a wee bit different from King's, is a wee bit different from Newcastle. You have all the knowledge, you have all the skills, if you like, to be a great junior doctor. It's just about applying those and the kind of problem solving aspects that go along with it, the kind of fatigue management, if you like, if you're finding shift work hard, the being able to communicate and work well within those teams. A lot of it comes down to actually soft skills, actually application of the groundwork which has been laid. And it's not a big jump, it is a big jump. But I think that having that kind of confidence in yourself that actually when and if it comes to that point, you will have all those foundations in place. So I certainly say at this point it's not a thing to be afraid of.
Thank you. We'll maybe try and squeeze in one or two more if we've got time. One of them that's coming is, do you get to choose where to do F1 and F2? For example, if you'd rather do it a city hospital or a more rural setting, do you get a choice in that?
Yeah, I don't mind kind of explaining that. In terms of effectively, yes, you do. I won't go into great detail on the system because it might change subtly by the time it gets round to your cohort doing it. But at the end of medical school, you have a kind of score allocated in terms of your decile of where you are graduating within the medical school. It's often assigned about kind of based on exams from a year before graduation or so. That goes forward to your kind of score that goes forward in your application for a foundation. Other things go into that, such as the situational judgment test, which you sit. There's been kind of debate about extra qualifications going into that. Intercalated degrees are not currently included, I don't think. But a kind of a sum is made and you're assigned a score. You then apply first to which area of the country you would like to go to. You find out if you've been allocated to that or not, but you rank if you're in the country. And then once you have your area, you then rank all the jobs within that area, and that lets you put in geographical preferences in terms of that, and then your ranks determines onto that. Specialist foundation, like going into big detail on it, is slightly differently arranged, and you have to apply for both if you're applying specialist foundation, and in which case you are applying to those specialist foundation jobs alongside that, and you obviously can rank those as well, so you can express a preference at every point. Sometimes people can put in extenuating circumstances that they may need to or have a strong preference to stay within an area as well, but that's done on a case-by-case basis.
Thank you. I don't know if you've got anything to add to that, Anna, at all, or
No, that was very succinct.
one last one, which I think maybe is a quick one, but you never know, is have either of you ever had any regrets for not trying a different profession?
Oh, that's hard.
Oh.
Anna, do you?
Yeah, I mean, I did. So, well, sort of. What I wanted to do if I hadn't done medicine was I wanted to be a journalist. So I actually spent a year at the BMJ, the British Medical Journal, working on their student section, where I got to do a lot of journalism and writing and editing. And it was brilliant. I really, really enjoyed it. And I still do some of that on the side. So I edit a foundation column for a journal called Clinical Medicine at the moment. So I had a bit of a taster of what it might be like to be a journalist. And at the end of the year, I was very ready to go back to medical school. So I think that was quite gratifying to me to find out that I made the right decision. But I think the other thing to say is, you can start medical school and not finish medical school. You can start medical school, finish medical school, become a doctor, and then decide that you don't want to be a doctor forever. There's no kind of obligation. And I know lots of people who indeed didn't finish medical school and are now doing a range of amazing things. And sorry to do a bit of a plug here, but when I was working at the BMJ, we ran a podcast called Sharp Scratch, which is still going, and I would advise you guys to check it out. It's run by medical students and junior doctors, and I did 2 episodes while I was at the BMJ about leaving medicine. So those might be interesting ones to listen to if you're kind of thinking about what exactly it is that you want to do, and medicine's an option, but there's other things on the table. But yeah, I think the other thing is, as Sarah was saying, you can maintain some of these things outside of medicine. So I now write a lot of poetry, and I do that outside of medicine. Some of them address like experiences I've had in medicine. Most of them don't. So, you still do have time to do other things that you enjoy. Your whole life doesn't have to be consumed by medicine.
Yeah, the same. I haven't had any. So I haven't personally taken any time out during my medical degree apart from to do an intercalated degree in cancer studies. If I were to go kind of sideways into something now, I'd probably step into cancer research. But I currently much prefer the patient-facing aspect of that. I really like being a doctor. Other things I explored when I was at the stage of being in senior and high school was engineering. I actually quite liked astrophysics as well. I really liked physics as a subject in school. I looked a wee bit at that, but thought I would like the people-facing aspects of medicine. And now I often think when I retire, I might do an anthropology degree. I really like people. So yeah, I don't. I personally haven't. I personally feel I've made the correct choice in terms of my career. But again, it's not a one-way track. You can step on, you can step off. You can do a medical degree, sets you up really nicely to do other things as well.